welcome you all. Yeah, okay, I'll start now. So, on behalf of the Society of Fetal Medicine, I welcome you all for the second episode of the Next Gen Expert webinar series. As you are aware that this was something which was conceptualized and started just recently, and we've already had one episode, and the concept was to you know cover up different parts of fetal medicine, but with a different perspective, because we have a lot of I won't call them as youngsters because they are already experts in their own sense, but who have phenomenal work, are very good speakers, and they can pass on their experience and their expertise so that we all learn from them. So today, in the second episode, we are going to take you through fetal phase part one, and we have three fabulous speakers, all three very good friends of mine who uh, young, very passionate about fetal medicine, very passionate about their work, and most important thing, what actually is very close to my heart, they're very passionate about their imaging. And so we have Dr. Alok Varshne, Dr. Naveen Pereira, and Dr. Varun Thakur, and they're going to take us through three different topics. And I request our secretary Rima to introduce the speakers and take the program forward.
Thank you, Bimal sir. You've introduced our dynamic speakers for today. I will now take you to request Dr. Alok Varshne, our dynamic. I think his images you all know are one of the most fabulous that we ever have, to take us through fetal phase in the first trimester and what should we look for in the first trimester. So, Dr. Alok, the audience are all yours. He has a huge introduction, but we know him for being one of the finest human beings and the best imaging person, one of the best imaging persons in SFM today. So, Dr. Alok, please take us through what we need to know in the first trimester.
All right. Thank you, Dr. Rima and Bimal sir, for the kind words. So today, I hope you can hear me and you can see my slide.
Yes, Dr. Alok.
Yeah. So I'll be speaking about the fetal phase in the first trimester and what to look for. And as we know, facial abnormalities, these are very important because these can be indicative of a chromosomal abnormality, a single gene disorder, or even a metabolic disorder. So in the second trimester, it is undisputed that we are going to look at the phase, whether it is ISWAG protocol, AIUM practice guideline, or any other guideline. Fetal phase is a very integral part of the anomaly scan. But do we really see, do we have to see the fetal phase in the first trimester? This is a question because in the ISWAG's minimum requirement for a basic structural survey, phase does not feature at all. We just need to check the nuchal translucency, whether it is less than 95th centile, and that is all. Phase does not figure in the ISWAG protocol. But if you see the embryology of the face, by 10 weeks, the structure of the face is complete. Only thing that remains is ossification of some parts of the fetal face. So by 11 weeks onwards, the face can be eminently assessed on prenatal ultrasound. And we all have expertise. We all see this kind of an image, the mid-sagittal plane of the fetal head and neck for our NT. And we know we can very easily see all these structures in this scan. We can see the forehead, the nasal bone, upper lip, mandible, and the palate. So we are familiar with this section. We know how this looks. And if there is any deviation, it is very easy to spot. And if we complement this with the cornal planes, so this is the retronasal triangle plane, and this is the cornal plane of the orbits, we can assess the face much more comprehensively. We will look at the nasal bones, the palate, the bony orbit, the eyeballs, the lenses, and we can even see the mandible and the ears if we add cornal planes in our imaging. Now, taking a cornal plane, it does not take much time. When you get a good section, the transventricular plane in which you are seeing the butterfly sign of the choroids, then you simply need to scan inferiorly and anteriorly, and you will get all these structures, the orbits, the retronasal triangle, the palate, the mandible, very, very easily. And you can even see the ears on both sides. And you can always complement it with a 3D ultrasound. For this, you will actually require a high frequency transvaginal probe because transabdominally 3D is not that good. But if you have an abnormality, if you want to look at the face closely, then 3D is the way to go. If you do a 3D, you will have very, very nice results, which is why the ISWAG guidelines say that for a comprehensive detailed evaluation, we need to look at all these structures: forehead, orbits, nasal bone, maxilla, retronasal triangle, upper lip, mandible. And notice that even this guideline does not mention ears, but they can always be seen in the first trimester. But there are certain challenges. Okay, it's not easy because what we are doing is we are concentrating on the part of the face of part of the body, which is maybe just about a slightly more than a centimeters in size. So we are looking at a very small part. It requires more expertise. Sometimes the diagnosis is going to be uncertain, incomplete, and there may even be false diagnosis. And this happens very frequently when we try to diagnose cleft lip and palate in the first trimester. Other challenge is that if you look at the common conditions that affect the face, the Down syndrome, palate, micrognathia, microtia, microphthalmia, and Binder's facies, then some of them, yes, Down syndrome and cleft lip palate, we can, diagnose them in the first trimester with great degree of confidence. Micrognathia is diagnosis possible in severe cases, but rest of the conditions, they are actually either very rare or they evolve in the second and third trimester. So the first trimester diagnosis is going to be challenging. For example, let's say Binder's facies. It is a common enough abnormality, but the literature says the incidence is 1 in 10,000. But the first trimester diagnosis is not possible because there are no findings. And similarly for microphthalmia, even if you see in the first trimester the eyeballs are normal, then microphthalmia can develop later in the second and the third trimester. So there are certain challenges, but we are going to assess the fetal face in the first trimester because there are certain abnormalities which will be very, very apparent even in the first trimester. So for example, these are the abnormalities. We can see the profile of the fetal face is grossly abnormal. We do not see the head at all. We do not see the forehead properly. The bulge of the forehead is gone. We do not see the cranial ossification. The head has bizarre shape, and this is exencephaly. Okay, so this is a part of the acrania, exencephaly, and anencephaly sequence. The skull bones have not developed. The brain is exposed to the amniotic fluid, and then it gets disintegrated. And then we have all these bizarre shapes of the exencephaly. And sometimes here we can see the head has flopped because the skull bones are not there. The brain is covered by the meninges. It is flopping onto the one side, and we have this is called as the beret sign. So we have very fancy names for all these abnormal shapes of the fetal head, but all these can be very easily identified in the first trimester if we take a close look at the fetal face. Similarly, sometimes we can see these big frontal encephalocele even in the first trimester. And even if the encephalocele are parietal or occipital, if they are large, they are going to cause smallness of the fetal head. They are going to cause the sloping of the forehead. And then even if you do not see the defect posteriorly, you will be alarmed, you will be alerted because the fetal face, the forehead is appearing sloping. Now, these cases can be challenging because the contour is not much altered. But if you compare with the normal, and if you notice that the head shape is slightly abnormal, it is appearing slightly small, and this should alert you to look at the posterior fossa. And here in the posterior fossa, we see that the three spaces, the brainstem, the fourth ventricle, the intracranial translucency, and the cisterna magna, these are not visible. And when we do not see any obvious defect in the skull, we need to look at the spine, and we will find in most of the cases an open spina bifida. So just by looking at the face, we can make a diagnosis. We can, at least be attempting a diagnosis of open spina bifida in the first trimester. Another obvious abnormality which affects the fetal face is loss of the fetal nose. The most prominent part of the face is the nose, and if the nose is lost, that is arrhynia, and usually this is going to happen when there's hollow prosencephaly, and most of the times it is accompanied by a midline cleft in the face. And hollow prosencephaly, as we know, it can appear with wide varieties of defects in the fetal face, and this is a cyclopia midline orbit, and a this projection which is arising from the forehead. This is a nose-like projection. This is the proboscis. So all these abnormalities of the fetal face, these are associated with hollow prosencephaly, and many of these are so gross that we can spot them even in the first trimester. What about Down syndrome? The reason for which we started doing the NT scan. So Down syndrome, as we know, is the most common genetic syndrome, and we spend a lot of effort in diagnosing Down syndrome in the first trimester. And in the face, there are clues for Down syndrome, and most important of them is the nuchal translucency. But we also have to look for the presence or absence of the nasal bone. We consider the nasal bone is present if it is appearing echogenic than the overlying skin. And if we consider them as absent, if it is not visible, or if the echogenicity is same or less than that of the skin. And we can complement this with the corneal plane, the retronasal triangle view, in which if the nasal bones are absent, it appears as the open apex of the retronasal triangle. And this view is also important to find out whether the nasal bone is unilaterally present or bilaterally present. And why nasal bones are important? Because these are absent in 60 to 70% patients of fetuses with trisomy 21, and only 2% of the normal fetuses will have absence of the nasal bone. Now, what to do if there's an isolated absence of the nasal bone? This seems to be a slightly controversial topic, because some people will prefer to do NIPT, some people will prefer to do invasive testing. We simply need to consider that if we use more markers such as absence of nasal bone, reversal of A wave, and tricuspid regurgitation in conjunction with the nuchal translucency, this increases the detection rate. This reduces the false positive rate. So we need to consider absence of the nasal bone in this light. Another finding that can be seen in Down syndrome, and it has fallen out of use these days, is the frontomaxillary facial angle. We know that the normal frontomaxillary facial angle is 75 to 85 degrees, but in the Down syndrome, it is larger than normal, more than 85 degrees. And this happens because the Down syndrome fetuses, they have a mid-facial hyperplasia. So if you draw a line along the palate and draw a line along the forehead of the fetus, this angle is the frontomaxillary facial angle. And in most of the cases of Down syndrome, this is going to be actually more than 90 degrees. So this is a good clue, but technically challenging, so it has fallen out of use these days. Now, another very common abnormality that affects the fetuses is cleft lip and palate, and we know that the cleft lip and palate, they can have variable degrees of extension. They can involve only the lip, then the alveolus, the primary palate, and even the secondary palate. But in most of the cases, we will see the cleft through and through from the lips to the secondary palate. So this is, it was considered very challenging to diagnose cleft lip palate in the first trimester, because the facial structures, particularly the lips, they are very thin, very small, and it is difficult to assess them in the first trimester. But today we can use two methods, which are very good methods to screen for cleft lip and palate. First is the maxillary gap given by Professor Rabi Choi. And second is the absence of the superimposed line sign given by our dear Lakshmi ma'am. So these two methods, if we employ, we can detect a very, very large number of cleft lip and palates in the first trimester. So maxillary gap, whenever there's a big defect in the cleft palate, we see it as a gap in the palate, the hard palate. This is the hard palate, and we see this as a gap over here. If a gap is more than 1.5 millimeters, this is more likely to be significant, and this needs to be confirmed in an axial plane of the maxilla or in the retronasal triangle view. Sometimes we can observe small gaps in the maxilla in the first trimester, and they are generally because of ongoing ossification process. So if the gap is less than 1.5 millimeters, it may be small. It may be absolutely normal. And we also need to know that the palate that we see on the sagittal plane, so this is the palate in the sagittal plane, it is composed of two bones. This is the vomer, the superior bone, and the palatine process of the maxilla. So when there's a defect in the palate, in the secondary palate, that's the defect in the secondary palate, the vomer bone is persisting, but there's a gap here in the midline in the palatine process of the maxilla. So if we take a section, a midline section, mid-sagittal section, what we are going to observe is we are going to observe only the vomer. The palatine process of the maxilla will not be visible. This is what is called as the superimposed line sign. So superimposed line sign, it is seen between 12 to 20 weeks of gestation. Whenever there's a defect in the secondary palate, we are going to see only the vomer bone, the maxillary palatine line will be absent. And this is a very good sign. It is seen in almost 90% of the defects of the cleft of the secondary palate. And most defects, as they are associated with the defects in the primary palate, alveolus, and the lips as well. So this is a very important method to detect cleft lip palate in the first trimester. So if we do the retronasal triangle view diligently, sometimes we can, as a screening method, we can see an eccentric defect, a paramedian defect in the heart, in the base of the triangle. This is the cleft lip and palate. Okay, and so both the maxillary gap and the superimposed line sign, they need to be confirmed with the retronasal triangle view. All these views are complementary to each other. So here is an example. This is about 12 weeks, 4 days fetus, and we can see the palatal line is interrupted anteriorly, and we see the absence of the superimposed line sign. We see just one line over here, that is the vomer, just one line, not two lines. And this was confirmed on a 3D examination. We can see there's a unilateral cleft lip and palate. And this can be confirmed even on the axial plane. And here we can see on the axial plane, there's a unilateral cleft lip and palate, which is extending through the alveolus, which is extending into the primary and the secondary palate through and through extension. And this could be diagnosed in the first trimester because of the two signs that I described. Another case, this is again same gestational age. We can see the maxillary gap over here. And then this was confirmed in the retronasal triangle view as an eccentric, as a paramedian gap in the base of the maxillary retronasal triangle. And I could see in this case with a high frequency transducer a defect in the lip as well. So if you employ these two signs, you will be able to screen majority of the cleft lip and palate in the first trimester. Bilateral cleft lip and palate, the diagnosis is slightly, I would say, easier even in the first trimester, because in most of the cases you will see this big maxillary protrusion over here, and this will alert us that there is something wrong with the lips and the palate, and then we can confirm it. And in these cases also, we will see the maxillary gap, we will see the defects in the retronasal triangle. But if you see atypical clefts which do not follow the usual pattern, then do a transvaginal ultrasound and try to look for amniotic bands. Here you can see there's a huge wide cleft of the fetal face, and this turned out to have amniotic bands attached with it. There was also, in this particular case, a parietal region encephalocele. What about the orbits? Now, orbits in the first trimester, the anomalies are quite rare and they are rarely detected in the first trimester. So yes, we do see the orbits in the first trimester, but generally speaking, I have not found many abnormalities in the first trimester. We need to look for the eyes very diligently if there are other fetal abnormalities or if there is a prior family history. The abnormalities like microphthalmia and cataracts, they are difficult to diagnose in the first trimester, and secondly they evolve over a period of time. So even if the eyeballs and the lenses, they are normal in the first trimester, it is not a guarantee. These defects can develop later in the second and the third trimester also. Similarly, abnormalities of the position, the hypotaylorism and hypertaylorism, these are again not very easy to identify in the first trimester because the size is too small. So whatever abnormalities that I have found in the fetal orbits are generally in the context of the hollow prosencephaly. So again, this is the case which I have already shown, cyclopia. And this is another case of hollow prosencephaly in which had a hypotaylorism. So generally speaking, these are the abnormalities which I have found, but I have seen many people, they diagnose microphthalmia and cataracts even in the first trimester. Now, another important abnormality of the face is microretrognathia, and Naveen is going to take us through the whole spectrum of microretrognathia later today. Now, micrognathia is small mandible, retrognathia is posterior displacement of the mandible, and most of the times these two are commonly concurrent. And if we take a nice midline sagittal view, we will be able to spot these abnormalities. Multiple causes are there. Nearly, 2/3 of them are syndromic. Many of these will present with a triad of micrognathia, glossoptosis, and airway obstruction. That is the Pierre-Robin sequence. Cleft palate is usually associated in cases of micrognathia or Pierre-Robin sequence. Now, in the first trimester, you can subjectively see that the mandible has receded, and you see this overhanging overbite. The lip is protruding. And if you are concerned that you want to objectify or you want to confirm in subtle cases, you can measure the prefrontal space distance. You need to draw a line along the mandible and from the anterior margin of the palate. And this line usually will cross very close to the frontal bone. But in cases of micrognathia, this is going to cross far away from the frontal bone. So this is a very easy way to find out whether we are dealing with micrognathia in the first trimester or not. Another way to confirm is you take the retronasal triangle view. Usually when we take a retronasal triangle view, we are going to observe a gap in the mandible. That's the mandibular gap. Whenever there's a micrognathia, we do not observe this gap. So if you see no gap in the retronasal triangle view, you are going to see that this baby may be having micrognathia. But in my personal opinion, I like to do the axial section of the fetal mandible in such a case, because in cases of micrognathia, the mandible will have a rounded shape, whereas usually it has a horseshoe shape. Okay, it has a horseshoe shape. If I see a rounded shaped mandible, that is going to be a case of micrognathia. So two cases I would like to show. One is this one. This is about 12 weeks fetus. We see there's micrognathia. The chin is receded, lip is overbiting, and you see there's a gap, maxillary gap is there, maxillary gap is over there, and 3D can depict all these abnormalities very nicely. And in the axial section, we can see the rounded shape of the mandible. And even at this early stage, you can see the tongue is occluding the pharynx. So this is a Pierre-Robin sequence with other associated findings. Another case, this is about 13 weeks fetus. You see clearly micrognathia. There's a maxillary gap, so there is a probably a secondary palate defect over there. Also, there were also small ears and there's skin tag on the face. So all these cases, they are likely to be syndromic. So we need to evaluate the fetus from head to toe in these cases because, as I said, two-thirds of these are syndromic. So, for example, here in this case, we can see micrognathia. There is a mandibular maxillary gap over there. And in this particular case, I was not able to find the femur. So this was diagnosed as femoral hypoplasia, unusual facies syndrome. The second point which I want to make is there are certain instances when you will see subtle micrognathia. So here you can see in the first trimester at 12 weeks, there is appearance of micrognathia, but mandible is something which is going to grow in the early second trimester. So in all the cases, all the borderline cases, it is always prudent to wait for at least 4 weeks and review the case. Most of the times the facial profile becomes normal, so no need for haste in these cases. Now, what about the ears? Examination of ears is controversial not only in the first but also in the second trimester, but they are there to be seen. They are not very difficult to be visualized. We need to remember that the external ear develops first in the lower cervical region, and as the mandible grows, the ear is going to ascend up. And by 12 weeks, we should be able to see the fetal ear at the level of the outer canthus of the eye. Okay, so that's the outer canthus of the eye. If we draw a line from the outer canthus to the inion, the ear is touching that at the time of 12 weeks of gestation. So this is a good way to identify low set ears. This is not something which you will do on a routine basis, but sometimes when you see associated abnormalities and you want to confirm whether there's a low set ear or not, simply do a 3D examination, draw a line from the outer canthus to the inion, and low set ear, it will be way below this line. And this is something which can be identified even in the first trimester. So this is a 12 weeks fetus. We can see the ear is way below this line, which is drawn from the outer canthus to the inion. So this is a low set ear. What about microtia, anotia, hypoplasia of the ear? One, these abnormalities are actually very rare, so difficult to spot in the first trimester. Second, ears are not part of any guidelines so far, so we do not pay much attention to these ears, but they can be identified. These abnormalities can be identified even in the first trimesters. So here you can see this is the normal ear on one side, but on the other side, the soft tissue of the ear is not visible, and this turned out to have a microtia in the second trimester. Binder species, as we commonly see it in the second trimester. But as I said before, this is something which will not be apparent in the first trimester, cannot be identified in the first trimester because the facial structures are still developing. But recently I had a case in which you can see this is the retronasal triangle, and you can see this echogenic line dividing the retronasal triangle. That is the calcification in the nasal septum. And at that time, I did not know what it was. But later on, when we examined the fetus again in the second trimester, and this fetus developed binders facies. So this makes sense because in most of the cases of binder syndrome, there is abnormal calcification of the cartilages, premature calcification. So the nasal septum cartilage got prematurely ossified in these cases, and this fetus later on was diagnosed to have binders facies. Then last case, so this is something which will be rare, but we can sometimes spot tumors involving the fetal face. But the most common is the teratoma, which is also known as epignathes. This arises from the oral cavity. It can originate from the sphenoid bone, protrudes from the oral cavity outside. It can also grow inside the brain and the face. Here we can see a huge mass involving the brain, then it is extending into the face and then protruding out of the mouth. So this is something which can be spotted even in the first trimester at times. So just to summarize, first trimester evaluation of the fetal face is important. So not only the nasal wound, we have to see the entire face. Yes, the evaluation can be challenging due to small structures and subtle abnormalities, but we know we can see a lot more in the fetal face if we do the examination diligently. You take the mid-parietal plane and evaluate it properly. And then you also take the retronasal triangle view, and both of these in conjunction, they will offer a comprehensive screening examination of the fetal face. At least start looking for cleft lip and palate, because this is something which is common and this can be easily identified in the first trimester in majority of the cases. Thank you so much.
Thank you, Dr. Alok. That was indeed brilliant and a lot of take-home messages for all our viewers. Thank you so much.
Thank you.
We now come to our second talk by Dr. Varun Thakur. Dr. Varun Thakur is another dynamic fetal medicine specialist from Greater Pune chapter. He's also the secretary of the Society of Fetal Medicine, Greater Pune chapter. He does wonderful imaging, and he will take us through posterior palatine line in the fetal cleft palate. Now, it gets difficult with every case. Dr. Varun, we would like you to take us through your talk. Thank you.
Thank you so very much, ma'am, for that kind introduction. Good evening, everyone. I hope I'm audible.
Yes, you're audible. If you could put up your slides, please.
Yes, ma'am.
Thank you.
Is it visible?
Yes, thank you so much.
Perfect. So, yeah, at the outset, I'd like to thank Khurana sir, Sahani sir, Rima ma'am, Mohit Shah sir, and Alok sir for giving me this precious opportunity. After that wonderful talk by Alok sir, even he showed some 50 odd cases in 20-25 minutes. That was a visual treat. I will take you through.
Dr. Varun, it is okay. Thank you.
Okay, all right. So I would take you through the posterior palatine line in fetal cleft palate. So first of all, I do not have as many cases as Alok sir, because this is a rather new topic for me and to everyone. So I will strictly stick to the palatine cleft. I will not talk anything about the cleft lip. So before we go to the posterior palatine line, we should understand the development of the palate. So this is the primary palate, which is actually formed by the fusion of the medial nasal process and the maxillary process. And this primitive palate will separate the nasal cavity and the oral cavity in the anterior part. But the nasal and the oral cavity in the posterior part is still continuous, which is later on separated by the palatine shelves. So the palatine shelves, initially they form, then they go downwards. The tongue is retracted backwards, and then these palatine shells will adhere and fuse to each other, thereby forming the palate. So we all know that left lip starts from anterior, and then it involves the alveolar arch and then the primary and secondary palate. Whereas the isolated palatine clefts, they start from behind, they start from uvula, and then they proceed anteriorly. So this is how the palatine fusion happens. Generally, the palate is developed by 6 to 10 weeks. The soft palate is also developed by 12 weeks. So this was the group which is from the University of Montpellier in France, which spoke about the posterior palatine line for the first time in 2017. They studied some 100 fetuses, and they could show it easily that the posterior palatine line can be very well documented in the mid-trimester anomaly scan. This was in 2017. In 2020, they came up with a semiology, with a classification for isolated palatine clefts, in the sense palatine cleft without cleft lip. So they proposed a classification also. But before going to the classification, what is the most important thing is to obtain an axial transverse view of the palate, and they have given an ultrasound quality score for the same, wherein we should show two pterygoid processes for which we get two marks, the alveolar arch, axial alveolar arch, for which we get 1 mark, and the orientation of the probe should be horizontal or less than 30 degree, for which we get 1 mark. So at least we should have a score of 3 to call it a satisfactory assessment of the posterior palatine line. If the score is less than 3, then we should not be assessing the palate in that view. We should get an optimal or adequate image so that we can comment upon palatine clefts. So this is our image, and we will see we have two pterygoid processes, so 2 marks for this. The alveolar arch in the axial view, so 1 mark for this. And we see that the probe orientation is perfectly perpendicular to the palatine bone. So this gives us a score of 4. Only when we satisfy all these criteria, we should do palatine assessment. Otherwise, we may erroneously diagnose posterior palatine clefts. So this posterior palatine line gives us a typical bat sign, looks like a bat. That's why it is called as a bat sign. The same group also gave us this classification of the palatine clefts. So type 1 palatine cleft is wherein we can see that the posterior palatine line is interrupted and the nasal spine is not seen. You see there is not much of elevation of the posterior palatine line. There is just interruption. Remember, type 1 is the one which has got the highest false positive rate. So always be careful when we are diagnosing type 1 cleft palates. Type 2 cleft palate, there is an elevation of almost 30 degree. Both the pterygoid processes are normal and the posterior palatine bones are slightly elevated. In type 3, there is complete disruption of the posterior palatine line and we can get a V-shaped structure in the midline. That is type 3 cleft palate. And in type 4, again, there will be complete disruption of the posterior palate and there will be a U-shaped, a large U-shaped cleft. So these are the 4 types of cleft palate which were proposed and given by the French group by Jean-Paul Faure and Florent Futz. So now coming to our cases. This is the first case. I would like to make it slightly interactive. So please also do participate in the chat box. This was my first case. This paper was published in 2020. I got to know about this paper in 2021. So started looking for palatine clefts in 2021. And this was my first case, which I got back in November 2021. So we can clearly see that there is a interruption in the posterior palatine line. I hope you guys agree to this. This lady came for a routine anomaly scan. There was nothing else, only this sign. So what happens is when you want to diagnose something for the first time, you would obviously need some backing. So I shared this with one of my senior colleagues, and he said it is normal. While I was very much confident that, I have picked up a posterior palatine type 1 cleft, but he said it is normal. You go and look for the uvula. So we can see that the uvula is present. We already know that cleft palates isolated will start from the uvula and will proceed anteriorly. So why in this case I had this picture was because if there was actually a cleft palate, the palatine bone would still have been slightly elevated. It would not have been bang horizontal. So that's why I said that type 1 cleft palate has an extremely high false positive rate. Whenever you get an interruption in the posterior palatine line, but the posterior palatine line is not at all elevated, go back to your uvula, check the uvula. If it is there, then this is probably a false positive case and it's not a type 1 cleft palate. Later on, this lady continued the pregnancy. Of course, I didn't tell them anything. I just verbally consulted my obstetrician friend and he said that everything was normal after the delivery and there was actually no cleft palate. So this was a take-home message that even if you see an interruption in the posterior palatine line, even if you follow all the criteria, the ultrasound scoring system by the French group, you may still have false positives. So do not be overzealous. Second case, this lady came for an anomaly scan. The fetus had multiple other findings. What we can see here is there is definitely interruption in the posterior palatine line, and there is some elevation of the palatine bone. So this was actually a case of cleft palate type 2. You see the elevation and the tongue is sticking in between. The fetus actually had a left club foot, and all the long bones were less than 5 percentile. So I didn't go looking for a cleft palate in this fetus. Anyways, it was a part of my protocol, but because the fetus had multiple other problems like short long bones, left club foot, and a cleft palate, I offered them an invasive testing. Obviously, the couple declined. They opted for termination. But then SFM was conducting a free autopsy, series with live cell. So they conducted this free autopsy, and I got the autopsy report. It was a preterm female fetus and had a facial dysmorphism with U-shape. Autopsy actually said U-shaped cleft palate, while I thought it was a type 2 cleft palate. And there was rhizomeric shortening of upper and lower limbs, and there was a left-sided club foot. Obviously, they didn't do a genetic testing, so I don't know the genetic disorder behind this fetus, but this was the story. That was my second case. This is a rather interesting case. NT scan done by me. Look at the ID 6334. NT scan done by me. NT was normal. I thought the superimposed line sign was there. Was not very sure, but then I thought probably it is there, so I passed it. The brain was also normal. We can see the butterfly sign there. Both the lower extremities were normal. And the heart also appeared to be good. So for me, this was a normal NT in the at 13 weeks. Lady obviously came at anomaly scan again. And at anomaly scan, I was surprised to see that there was a club foot, and there was also ventriculomegaly at 19 weeks, 2 days. And this was the finding. There was one more finding. If you see, there is nothing between the heart and the sternum. There should have been a thymic tissue there, which I am unable to see. You can see the 3-vessel trachea view. Both the great arteries are actually reaching or touching the sternum. There was nothing in between, and there was a cleft palate. I just couldn't see the posterior palatine line. What we can see is in the vomer in the midline. So this was actually thymic hypoplasia, a ventriculomegaly, cleft palate, and there was also an echogenic focus. So I counseled the couple again for an invasive testing. Again, they did not opt for it, but they opted for a genetic testing post-abortion. So that was the post-abortal picture shared with me by my friend Dr. Kiran Thorat. We can clearly see that there is a cleft palate and the thymus was hypoplastic. Normally, the thymus should be covering all the great arteries and even the upper part of the heart. Look how a normal thymus looks like. This image was given to me by Dr. Hima Madam from Hyderabad. So the normal thymus should cover all the great arteries and the upper part of the heart, wherein in my case, the thymus was just in the high superior mediastinum. So this was a case of hypoplastic thymus as well. The couple was sensible. After looking at all these findings, they opted for the genetic testing. They did a abortal testing, and not so surprisingly, we had this 13q12.11 microdeletion. This was a pathogenic variant which was found for these findings, which were reported on ultrasound: cleft palate, aplasia or hypoplasia of the thymus, ventriculomegaly, and echogenic intracardiac focus. So this couple made a sensible decision, and we could find out a definitive pathogenic reason for these findings in this fetus. Now, this lady again came to me a couple of weeks back. This time everything was normal, but I have a lateral ventricle which measures 9.8 mm. I have offered them an invasive testing. They said, we will let you know. They're going to take another 2 weeks. Probably they're going to come to me again tomorrow, and then maybe we'll see. But there was no club foot this time, no thymic hypoplasia, no palatine cleft, non-consanguineously married couple. So let's see what happens. Let's hope and pray for the fetus. Next case, again came for an anomaly scan. What we can see is there is clearly interruption of the posterior palatine line and almost a V-shaped cleft here. This fetus also had a bilateral SVC, and you can see that the aorta is relatively smaller. So a V-shaped cleft palate, a small aorta, bilateral SVC. There was thick nuchal fold, thick as well at 21 weeks. Certainly we can see that the nuchal fold is thick. And I thought probably the ears were low set. We already know now, because Alok sir has beautifully demonstrated how to look for low set ears. I thought that it was below the line drawn from the upper border of the ear to the eye. So I thought it was a low set ear. So I counseled this patient for invasive testing. Fortunately, this time they opted for an amniocentesis. We did amniocentesis. We did a whole exome sequencing for them, but it turned out to be normal. There were no copy number variations, and there was actually nothing in this fetus which was related to the given phenotype. This lady is still continuing the pregnancy. We'll get to know after the birth what exactly it was, if at all it was any other condition. Next case, this case actually came to me. This lady actually came to me only for a growth scan. All her scans were done outside. The fetus was already diagnosed as micrognathia, but at 30 weeks, when I did axial scan, I couldn't see a posterior palatine line. So now I had micrognathia. I had interruption in the posterior palatine line. We can clearly see that there's a huge U-shaped defect. So this was a cleft palate. And then I started thinking of Perry-Robin sequence. And after a long time, this fetus showed me this. Can you see the tongue? Tongue is vertical, is fallen back, and is actually riding over the remaining of the palatine bone. Normally, if you see, the tongue nicely reaches the floor of the mouth in the mandibular fossa. That's a normal tongue. Whereas you see the tongue here is vertical and is riding over the palatine bone. So this was a classic case of Perry-Robin syndrome diagnosed at 30 weeks. Unfortunately, 2 weeks later, because this child also was growth restricted, 2 weeks later, it became an IUD. The consultant could not give me the photographs, but he confirmed that it was a Perry-Robins. So if we can do all these things in the second trimester, can we not do these things in the first trimester as well? So I've been doing this. We already have a superimposed line sign in the first trimester, which is a very strong indicator. I've also tried doing the posterior palatine line in the first trimester. This is at 13 weeks, 4 days. This is at 12 weeks, 6 days. We can actually see the posterior palatine line in the first trimester as well. But can we use it to diagnose palatine clefts in the first trimester itself? Let's have a look. So this case, NT scan at 13 weeks, 6 days, NT, IT looks normal, but you see the mandible is short, it is receding. So this is probably a retrognathia or a micrognathia. Superimposed line sign is slightly there. But if you're careful enough, which I was not, this was told to me later on yesterday when I was discussing this presentation with Lakshmi Ravi madam. She said that, Varun, even if the superimposed line sign is there, but you closely observe the inferior line, which is actually the palate. The superior part is the vomer. The inferior part is the palate. This is not continuous. It should have been reaching till the posterior border of the vomer. So here it is missing. So the superimposed line sign told me that probably this is a posterior palatine cleft with a micrognathia, could be a Perry-Robin. I tried documenting the posterior palatine line in the first trimester here. I have scanned from the orbits. The neck is extended. We know that for palatine assessment, we need an extended neck and a good amount of fluid in the oral cavity. I still could not document the posterior palatine line. That's not just because that palatine line is absent. It is because in the first trimester, the posterior palatine line is actually paper thin. It is very difficult to demonstrate it even in normal circumstances. In abnormal circumstances, even it is even more difficult. So in the first trimester, rather than going with the posterior palatine line, a much more strong pointer or an indicator is the superimposed line sign. Here we all know that the superimposed line sign will have a premaxilla in the anterior 1/3 and the secondary palate in the inferior part, the vomer in the superior part, forming the three echogenic structures. In my case, the posterior echogenic structure, posterior and inferior echogenic structure was not there, telling me that there was a palatine cleft. I suspected a peri-Robbins. This fetus also had a solitary reniform structure in the pelvis. The couple obviously was not keen on continuation. They terminated the pregnancy. But I got my post-abortal pictures. We can clearly see the tongue falling back and there is a U-shaped cleft in the palate. So this was a case of peri-Robbins, again diagnosed in the first trimester. I did not diagnose the problem in the superimposed line sign when I was doing the scan, but I got to know about it only when I discussed this presentation yesterday with Lakshmi Ravi ma'am. So thanks to her for giving me that important point. So take home message from my presentation is posterior palatine line is the only thing that we need in second trimester. Remember, only in the second trimester. You might argue that, Varun, most of us, we all know that cleft palate starts from uvula. So why do you need a posterior palatine line? The thing is, if we start looking for the uvula alone, many a times we may mistake the glottic folds for uvula. And remember, uvula is an indirect or it's a surrogate marker for cleft palate. It's not a foolproof marker. The foolproof or a direct indicator is interruption in the posterior palatine line. So we should always look for the posterior palatine line. Don't be overzealous. As I said in the first case, I was being overzealous. I tried to diagnose a second trimester type 1 cleft palate, which was not the case. So I had to go back to the uvula. So only when you have no elevation of the posterior palatine line, but there is an interruption, you go and see the uvula. Otherwise, the posterior palatine line, if it is intact, then it is fine. Whenever there is micrognathia, always think of PRS. If you're dealing the first trimester, always document the superimposed line sign. It's a wonderful sign given by our own Lakshmi Ravi madam. If that sign, if the superimposed line sign is present, if all the three echogenic structures are intact, then there is no PRS. And in the second trimester, of course, we have to look for the posterior palatine line. Whenever in doubt, we should refer to a higher center rather than labeling it as a cleft palate, because whatever we say, patients may understand it in a different way. Even if we say that there are small findings, they may take radical decisions and unnecessarily they may terminate these fetuses. Posterior palatine clefts can be repaired and we need not write death sentences for these abnormalities. Although we should pick them up, this is not a part of any guideline. If you incorporate them in your routine protocol, it is very good, but do not write death sentences for these things. And in all the cases, I've shown 6 cases here, of which 1 was false positive, 5 were isolated palatine clefts without cleft lips. But remember, all of them had other structural abnormalities. Even the French group, which has studied and given this classification, they had some 43 cases of cleft palate without cleft lip, of which 34 had some or the other associated abnormality. Only 9 were isolated, truly isolated cleft palates. So whenever in doubt, we should refer them to a higher center. And lastly, superimposed line sign is a super sign in the first trimester. Do not forget it. We generally focus ourselves only, I'm not talking for everybody, I'll talk for myself. Generally, I'll focus myself on the NT, IT, intracranial structures, also on the nasal bone and mandible. We will see the integrity of the hard palate, the maxillary gap also, but not the superimposed line so diligently, which I should be seeing. So yesterday, Lakshmi Ravi madam opened my eyes. Thank you so much, ma'am, for that important input. And that's how I wrap my presentation. Thank you so much for your patient listening. Thank you all. Thank you, ma'am, again for the opportunity.
Thank you. Thank you, Dr. Varun. Indeed, brilliant. And I think all of us here, all the 487 people watching today, will start seeing the posterior palatine line from tomorrow morning. Thank you. And it was amazing presentation.
Thank you, ma'am.
Thank you from the entire SFM family. And now, before we go on to our final talk, I would request our trade partner videos and a reminder to everybody to register for BasicOn. So this is just a glimpse of what's coming in the BasicOn. So can we have, so we move on to our last talk by another dynamic fetal medicine person, Dr. Naveen Pereira from Ludhiana. And he's also a very energetic member of the society's center executive member of the Society of Fetal Medicine. Now he'll take us through fetal micrognathia, diagnosis and implications. Dr. Naveen, the floor is all yours.
Thank you, ma'am. I'm just sharing my screen. Okay, am I audible, ma'am?
You're audible. Your screen is visible. If you could take it to full screen mode, please.
Yeah.
Thank you.
Right.
He's another very decorated warrior of Society of Fetal Medicine.
So, good evening, dear friends. It's indeed an honor and privilege to participate in this webinar. My sincere thanks to Dr. Khurana sir, our mentor, Dr. Bimal sir, Dr. Mohit, Dr. Rima, and my dear friend Dr. Alok for this opportunity. I'll talk to an interesting and challenging topic. Dr. Varun and Dr. Alok have definitely touched on that, but we all learn by repetition. My talk is fetal micrognathia diagnosis and implications. First things first, a little bit about clinical embryology, clinical relevant embryology. So the mandible basically develops from the Meckel's cartilage. The Meckel's cartilage in turn develops from the first brachial arch. The posterior part of the Meckel's cartilage gives rise to the auditory ossicles and the sphenomandibular ligament, whereas the anterior part, around the anterior part, ossification takes place, and this in turn forms the mandible. When we're talking about mandibular defect, the most severe form is called agnathia or absence of mandible. Then we have a small and undersized mandible, which is called micrognathia. And when the mandible is positioned backwards in relation to the maxilla, also called a receding chin, this is called retrognathia. The prevalence is around 1 by 1500, and micrognathia is always accompanied by retrognathia. The opposite is not always true, and therefore there are rare situations in which there is retrognathia but not micrognathia. Now, this is a rare instance of a case of agnathia, as we see on the right-hand side. In the sagittal view, we see this image in which the chin is not seen, right? And there's a large defect of the chin, the mandible is not seen. And in the coronal view also, we see the nose and the upper lips, but the lower lip is not seen. And then when we have to find micrognathia, how do we find out in a case, is there micrognathia or not? And we have to know the different degrees of micrognathia. It could be normal or it could be severe. What is the way to find out? The way to find out, the easiest way to find out is looking at the mid-sagittal plane, the subjective assessment of the profile view. And we all know the mid-sagittal plane that we use in the first trimester for the anti-scan. And what do we see in that? The landmarks of the mid-sagittal plane is the tip of the nasal bone, anteriorly the hard palate, the rectangular broad palate, the lips. We see the thalamus in the midline and nuchal fold posteriorly. But if the image is not taken in that exact mid-sagittal plane, we can get an erroneous result of micrognathia as we see over here. So to avoid false positive and false negative diagnosis, the image has to be taken in the exact mid-sagittal plane. And also, the pattern recognition is easier by turning the image upright as we see over here. And we also see another interesting thing, that in this image of micrognathia, the lips are slanting down. Now, in subjective assessment, we also look at the axial plane. When we look at the axial plane, normally the palate is triangular or horseshoe shaped. But in microretrognathia, what happens? There's a flattening and it becomes round. And after a subjective assessment, we have a semi-objective assessment that Dr. Alok has already talked about. of the face profile line that should pass close to the forehead, and in micrognathia this passes actually away in anterior to the forehead. Now, 3D surface rendering definitely helps. And in this, as we see, this can add to the diagnosis and to the beauty of images also. And we can also show it to the patients if we are going to convince them about the abnormality. MRI is an adjunct to diagnosis. It helps in situations, especially where there is adipose stain oligohydramnios. And however, it's impracticable to use MRI as first-line screening modality due to cost implications. In glossoptosis, however, it has got a great advantage over ultrasound because it outlines posterior palatal defects very well against the high fluid signal fluid in the nasopharynx. Now, when we are talking about objective assessment, very often it can be a challenge to diagnose retinopathy, but it may not be so evident, and the findings might not be so convincing. That is when we may need objective evidence. There are nearly 30 biometric parameters mentioned in literature. I'll just discuss two of the more popular measurements, which are the inferior facial angle and the jaw index. And what is the inferior facial angle? It is measured in a mid-striatal view of the fetal profile over here, right? And there's at the crossing of two lines. The first line is drawn perpendicular to the nasion from the forehead, and the second line joins the tip of the mentum and anterior border of the more protrusive lip to join the first line. And this line is basically normally around 65 degree plus minus 16. Though if it's less than 49 degrees, it's considered abnormal with a sensitivity of 100% and also a specificity of 100%. So this is a case of micrognathia over here. And sometimes we see in the second trimester, we find something like a micrognathia. We see a retinopathy or micrognathia in second trimester. And in the third trimester, we might find that the face looks normal when we measure the inferior facial angle again. This is because the inferior facial angle actually increases slightly with gestation till about 30 weeks and therefore decreases minimally thereafter. So in these cases, what we need is another index, and that index I will talk about is the jaw index. Now, this is measured on axial view of the fetal mandible, where a line is drawn connecting the bases of the two rami. This is called the lateral diameter. Then there's another line drawn, that is the AP diameter from the symphysis manti to the midpoint of this line. This AP measurement is then divided by the BPD and multiplied by 100 to derive a ratio. This is called the jaw index. If the jaw index is less than 23, this has got a very high sensitivity to pick up microretinopathy. And the advantage of jaw index is this is independent of gestation age, and fetal position is not a hindrance as when we measure inferior facial angle. There are other tools that I'll just touch upon, like mandibular maxillar width ratio, which is if below is 0.78 is considered abnormal, and FNM angle less than 142 degrees considered abnormal, but they have a low predictive value. Now, we have seen micrognathia, we have diagnosed micrognathia, but what are the cause of micrognathia? Now, this is rarely an isolated finding. Even if when we're doing an ultrasound prenatally, it appears isolated, we have to understand there could be an underlying syndrome which could be found late at birth or at autopsy. So, most common causes of there are multiple genetic association with micrognathia. About 50 to 60% of cases could be associated with genetic conditions. And the most common group of conditions over here in this table that we have is chromosomal abnormalities. About 44 to 65% in different series have shown to have chromosomal aberrations. And the most common chromosomal abnormality is trisomy 18 or triploidy. There could be others like Turner syndrome, DiGeorge syndrome, deletions on chromosome 4, 5, trisomy 13, 9, and 8, and Pallister-Killian syndrome. Then we could have a second group of diseases called primary mandibular disorders like Pierre-Robin sequence, Treacher-Collins syndrome, cerebrocostomandibular syndromes, mandibuloacular dysplasia, and oromandibular limb syndrome. The third group of diseases that can be associated with retromicrognathia are arthrogryposis, Pinot-Shocker syndrome, multiple pterygium syndrome, osteochondrodysplasia, seen in skeletal and neuromuscular diseases. There could be the fourth subtype, which are gamut of different types of syndromes like Meckel-Gruber, Noonan, Smith-Lemli-Opitz, and Russell-Silver, etc. Now, we have this case that we saw in the second trimester at 20 weeks that presented with severe micrognathia over here. We can see this in this video, the receding chin, very small jaw, and this also had an aberrant right subclavian artery and severe FGR. The fetal weight was at the third centile. Invasive testing was done. QFPCR CMA revealed trisomy 21. And the second group of disease that we'll talk about is primary mandibular disorders. And we have to understand when there's a receding chin, the tongue is pushed back away from the alveolar ridge, as we see over here. This is the alveolar ridge, and this pushed back up from the alveolar ridge towards the posterior pharyngeal wall. And this also abuts the soft palate. This feature is called glossoptosis. So this is a cascade of events, micrognathia causing glossoptosis, and glossoptosis in turn causes airway obstruction. That's why this is called Pierre-Robin sequence. And this is what we see normally. The tongue is touching the anterior alveolar ridge. You have seen the imaging in the striatal sections. Now we see them in the axial sections. What do we see over here? We see that tongue is pushed back from the alveolar ridge over here, as we see in this arrow is pointing out. And normally the tongue should be touching the alveolar ridge. This case also had preaxial polydactyly, as we see over here. This case was, however, lost to follow-up. And then we have another instance, that feature that we see in Pierre-Robin sequence, accompanied by cleft palate. Now, cleft palate is very, very commonly seen with Pierre-Robin sequence. And why is that? That is because what happens is the retroposition tongue is pushed up, and while abutting the hard palate, can hamper the normal development of the palate. As we see this clefting over here, this unilateral cleft over here. And we see the flow across the palate over here in this striatal section. Now, this is an interesting recent sign for glossoptosis that we saw in literature in 2021. We see that there's a normal fetus over here. This is the image of the pharynx in the anterior cornal plane, where we see the uvula, epiglottis, and vocal cords are seen. Normally, this is fluid filled, and this is only partially filled by the tongue when there are sucking and swallowing movements. But when there is glossoptosis, the tongue completely fills the pharynx. This is called the tongue-filled pharynx sign in glossoptosis. Now, when we're talking genetics in Pierre-Robin sequence, about majority of them are syndromic, about 60% of them associated with the SOX9 gene. 20% can be non-syndromic, and 20% can be associated with congenital malformations. The other syndrome that we could be talking as a primary mandibular disorder is Treacher-Collins syndrome. And basically, when with this triad of micrognathia, glossoptosis, and posterior cleft are seen with deformed external ears over here, as we can see, that is basically Treacher-Collins syndrome. And also there could be a down-slanting palpebral fissure, which can help in diagnosis. This is an autosomal dominant condition. The mutation is detected by chromosomal microarray, but genetic confirmation can be challenging at times. There are few prominent personalities with Treacher-Collins syndrome. Now, the third group of disease, I'll talk about the case over here of arthrogryposis with skeletal and neuromuscular diseases. And we have this micrognathia over here. We have bilateral club feet. And in this video, we can see the hyperextended knees. We see the flexed elbows. We see the clenched hands. This has got arthrogryposis has got multifactorial etiology. KT, CM, and exome sequencing can be carried out. In this case, we did a microarray, and turned out to variation of unknown significance. Now, this was another case basically showing micrognathia. And what we saw is, along with the micrognathia, there was thickening of the skin. And apart from that, there was a flat nose and everted eyelids, as we see over here, and everted lips, as we see over here. And there was turbid liquor, and this was basically Hallucian ichthyosis. The mutation over here is in the ABCA12 gene. This is autosomal recessive condition, and this presents in the third trimester, as does arthrogryposis. Dr. Alok has already talked about first trimester diagnosis. So we have this case over here in which basically we saw retrognathia or severe micrognathia in the first trimester. In the sagittal profile, we can see this very well. We have this another sign over here that's called the mandible gap, which is seen present in the prenasal triangle view. That's seen normally, and here we don't see that gap. This is abnormal. This case also had increased NT about the 99 centile. The beta SAG and PAPA were low, and we had an invasive diagnosis. It turned out to be trisomy 18. We had another case in the first trimester. This was micrognathia, there was a cleft palate, absent femur, and this turned out to be femoral hyperplasia, unusual facies syndrome at 12 weeks. Now, this case we suspected to be having retrognathia in the first trimester with the absent mandibular gap over here and a small, evident kind of a small chin over here. And when we saw this in the second trimester, it turned out to be normal. The inferior facial angle was absolutely okay. So the learning objective for me over here is when we have situations when we have suspicion of retrognathia in the first trimester, we need to follow it up to confirm. Now, this is a case of isolated retrognathia at 20 weeks. And we saw here there was no glossoptosis, there was mild retrognathia, invasive test was done, and CMA was done, which was okay. Patient decided to continue the pregnancy. And when she continued the pregnancy in the third trimester too, the findings persisted. And they were even confirmed after birth to be mild retrognathia, and the baby is doing absolutely well as of now. Now, we can switch on the light bulb in our brain. I've tried to enumerate some associated clinical features in cases of microretrognathia to help us point to a syndromic association. Here, we are using micrognathia as a sentinel. We can use Sonia or Phenotype software also to help us likewise. Like, for example, if there are joint contractures with micrognathia, there could be arthrogryposis, Pino-Shocker syndrome, Zellweger, mandibular achial dysplasia. With CSD, it could be aneuploidies, chromosomal microdeletion, DiGeorge syndrome, cerebrocostomandibular syndrome. With clefting, it could be primary mandibular disorders like PRS and Treacher-Collins, or it could even be oral facial digital syndrome, femoral hypoplasia, unusual faces syndrome. With club feet, it could be aneuploidies and microdeletion, Smith-Lepli-Opitz syndrome. With polydactyly, it could be aneuploidies and microdeletion, Meckel-Gruber, oral facial digital syndrome. With microcephaly, it could be trisomy 18, Smith-Lepli-Opitz, Miller-Decker, cerebrocostomandibular syndrome, or even achondroplasia, which could also be seen in short, long bones, along with chondrodysplasia punctata. With renal anomalies, it could be cornea de Lange, Meckel-Gruber, trisomy 18. With CNS, it could be Miller-Decker, Meckel-Gruber, or triploidy, or Zellweger syndrome. Or with enlarged NT, it could be Noonan's Pino-Shocker phenotype, or the most common type that we see is aneuploidies. Now, before giving a thumbs up, we have to be wary for the prognosis, because we have to always look for associated anomalies, whether it's the first, second, or third trimester. Look for chromosomal anomalies, non-chromosomal anomalies, other associations. We have to understand that not all syndromic signs will be seen prenatally. Think genetics. We may need to do a karyotype or microarray, exclude primary trisomy 18 or other chromosomal abnormal rearrangements. We take a family history, take a genetic consult. If there are known mutations, we think of PCR or Sanger's. Otherwise, we may even think of exome. We need a proper prenatal counseling and postnatal clinical evaluation. If there's a termination of pregnancy, we have a detailed autopsy. Now, we may have postnatal complications if, as we have discussed in, like, for example, in Pierre Robin sequences, the tongue is pushed back. This leads to severe airway obstruction in more than 50% of cases. So this will require intervention. So we need tertiary care over here. And around 1/3 of cases would be having feeding difficulties. 1/3 would be having mild to severe long-term developmental delay. And the recurrence rate over here depends on the etiology. 1% for aneuploidies, up to 50% for autosomal dominant syndrome. So decision of the patient is their own personal opinion, and termination is seen very, very often because of the varied etiology and different kinds of anomalies that we see over here, the severity of the anomalies. And for pregnancies that continue, serial growth scan should be undertaken. We have to focus on LICA because of the absence in swallowing over here. This will lead to increase in LICA or polyhydramnios, and that could be fit. And we also have to look at the fetal movements to detect a neuromuscular disorder. Regarding management, we have to look for associated anomalies, whether it's isolated, whether it's Pierre Robbins, whether without clefting or associated anomalies. We always have to take a proper family history. We have to do a prenatal invasive testing, advice for that, in which we might go for karyotype, microarray, or even exome. And with the results, patients are concerned regarding about what can go wrong with the patient, with the baby, and they might even offer termination of pregnancy. If they continue pregnancy, we need to follow up every 4 weeks, look for the LICA, and deliver in tertiary care with the proper neutral care and airway support. My closing comments are, it's microretronathia is diagnosed usually subjectively in mild cases, and we may need to use objective evidence. 3D and MRI will help. In Pierre-Robin sequence, micrognathia, glossoptosis, airway obstruction, frequently cleft palate will be seen. Look for associated anomalies. In view of the high probability of genetic association, advise genetic consult. Family history and evaluation is important. Termination of pregnancy an option. For pregnancies that continue, we have to follow up, focusing on the fetal movements and amniotic fluid volume, delivering tertiary care with proper airway support. Risk of recurrence depends on etiology, 1% aneuploidies and 50% in dominant inheritance. Truly isolated micrognathia may be infrequent, and once the prognosis may be good once the genetic associations are ruled out. My parting message is continue to be a student, never stop learning, and thank you everyone for patient listening. Thank you so much.
Thank you, Dr. Naveen. I think it was a brilliant talk, and micrognathia is something like a Pandora's box for genetic disorders. So we need to look and look further. Thank you so much for those 3 wonderful talks, and really grateful. And I think people were glued to their screen. Thank you so much. I would now request Dr. Bimal Sahani to kindly take over the questions that are in the chat box, please.
Yeah. At the onset, I would like to congratulate all the 3 speakers. Wow, this was just out of the world. Like taking up a small topic, building a full-blown lecture through this on it. And then the best part is it was all backed with cases. So we learned from their positive cases also. And also, I was very impressed when they talked about the limitations, or how they made a false positive suspicion. And I think that's very important as far as learning is concerned, because that is what you go through on a day-to-day basis in your practice. And bringing that out, that too at a young age, and coming and saying, yes, I made this mistake. And it's not just admirable, but it actually teaches us, yes, this is how we can go wrong. And so my kudos to all 3 of you for this wonderful thing. And with 485 people, this is the kind of attendance we used to get during COVID. And Alok was saying, sir, you stopped giving webinars because there was hardly any attendance. And look at the demand for those young experts. This is great. It's very soon, Rima. I'm sure these youngsters are just waiting for an opportunity to give us a lifetime achievement award and push us off the radar. But yes, we are still there. So I'll take you through some of the questions I would want these young experts to answer. There was one by Dr. Gaurav Gupta: what to do if we are not sure on NT scan if the nasal bone is absent or not? Echogenicity sometimes is very subjective.
Yeah.
Alok, would you like to take?
Yes. So very important that you take the section in a proper orientation of the fetus. So the angle of insonation should be at least 45 degrees to the nasal bone. And if you are not sure, then echogenicity, then you can try TBS, try different positions. If you're still not sure, then you label it as absent or unossified and proceed accordingly.
Alok, can it happen that this can be a very, very common problem when you are dealing with a CRL of 45 to 53,
Yes,
54?
absolutely. As I said in my talk, if you do it very, very early, closer to 11 weeks, 11 weeks or less than 12 weeks, then it is very common that you will not be able to see the nasal bone because it starts ossifying at 11 weeks, but most of the times we start seeing at 12 weeks onwards.
And do you also agree that, in the Indian population, you have a slight delayed ossification that happens?
Um, In the Southeast Asian population, yes, in general, the ossification occurs a bit late, but statistically, there's not much difference. The nasal bones, they are shorter, definitely compared to the Caucasian population. But overall, the ossification pattern may be a bit delayed, but not by much. So, yeah, but the preferred
So,
is 12 weeks plus.
so the message should be that we should do our NT scans between 12 to 13 weeks, 2 days, 3 days, So we should, it's always better to do your nuclear translucency scan with a CRL of around 55, 56
Right.
plus. You may end up otherwise making these subtle mistakes, which can, and so in cases of doubt, you still feel it is appearing isoechoic or something, you can call the patient after 4 or 5 days and confirm, and then go into a battery of tests. So, you know, when this is Dr. Avinash Gomkale who's saying when maxillary gap sign is present, there is a gap in vomer as well.
No, there is no gap in the vomer because the defect is in the palate. It is in the alveolar process of the maxilla, the palatine process of the maxilla, sorry. So there's a gap there. The vomer is the overhanging bone that is forming the nasal septum. So there's no gap because it is developing separately.
But its alignment can get a little
Yes.
altered
Yes,
because
it
of the
can get
defect,
alignment. Yes.
and that is why you may actually see that, because vomer as such is not an exactly, the defect is not in the vomer as such. Very true. Again, unilateral absence of nasal bone, should it be considered as absent nasal bone?
So this is a bit controversial because we do not have enough data, but by consensus today, we feel that the unilateral nasal bone's absence should also be considered as absence of the nasal bone.
Should we wait in all cases of micrognathia or only in borderline cases? Should we wait for what? Gaurav Gupta is asking, or maybe probably he's asking that should we wait for the right planes in borderline? Uh, so how to define micrognathia in borderline cases? That is a precise question,
No,
actually.
I think he wants when do we ask for follow-up? Okay, so
Okay, okay.
if there's a severe micrognathia, it is apparent in the first trimester, especially if you have associated findings, you can make a diagnosis then and there. But even in those cases, it is always prudent to wait. It is always prudent to wait till at least 16 weeks and then confirm your diagnosis. And by that time, you will also start seeing additional findings which may not be apparent in the first trimester. So this helps in the diagnosis. And what about borderline cases? Borderline cases are borderline cases. When you subjectively see something that the chin is appearing little small, it is pushed back, but you're not sure that it is micrognathia. The shape of the mandible looks all right, the size looks all right. So those are the borderline cases in which definitely before even committing on paper, I would ask for a follow-up.
Yeah, borderline cases look at the parents also.
Yes.
Yes.
Yes, sometimes it
proper
could
family
just be,
history.
yeah. It could just be familial. Then there are a lot of appreciations coming, and then we have uh, how, sorry, one is unilateral absence. Okay, that is the same one. Then we have one question: how to differentiate between epignathus from the fetus in feto involving maxilla.
This is you know when we think about fetus in feto, we always think about it happening in the abdomen, but it can definitely occur in any part of the body. It can happen in the neck. Rarely it may happen in the facial region, but ultimately it is like a teratoma. We will see well-defined bones in fetus in fetu. We will not see well-defined bones in a teratoma like epignathus that we see. This is the only differentiating point that I know.
That's the only differentiating point. Wonderful. How does normal uvula look? 2 lines or 4 lines?
2 lines equal to sign. It will look
Equal
two. It
sign.
will show 2 lines.
Somebody has asked Varun if there are any USG images of uvula in cleft palate cases. Okay, maybe
So-
some other time. Yeah, so probably he's asking whether you don't see the uvula
Yes.
or you can have even a bifid uvula and all. Are you able to appreciate it on ultrasound?
So personally, I haven't seen a bifid uvula on my own, but I saw one on a WhatsApp group. The case was posted by Dr. Dilip Ingole, sir. So that was the one which I have seen. For all my cases of cleft palates, because there are definite cleft palates, obviously the uvula will be affected and it will not be seen on the ultrasound images.
Or has it sometime happened with you that as a part of routine, do you look at the uvula as a part of routine,
No,
Varun?
sir. No, sir. I look only for posterior palatine line. I do not. I don't have uvula in my routine protocol.
So
Uh,
my
I, mine is the other way around. I look for the uvula in all the cases because
my way is that, if the baby is in the axial plane, I will look at the uvula. If the baby is facing up, I will look at the posterior palatine line.
Okay.
Perfect.
but Varun,
Yes,
I
sir.
would like to ask you, in cases of cleft soft palate,
Yes.
what would be the finding that you will get? Isolated soft palate.
A bifid uvula, sir. Type 1 cleft. There will be a bifid uvula. And if I'm only looking at the posterior palatine line, then certainly I'm going to miss out on those.
So, can you give a message embryologically that if you find a normal uvula, then there is no chance of a posterior palate
Right, sir.
defect?
Yes, sir. But then I had a similar point of view before. But then when I spoke to Lakshmi Ravi madam, she said our eyes are trained to the equal to sign, and our eyes will only recognize the equal to. That equal to may be a uvula, or that equal to may be the glottic folds also. So our eyes or our brain will actually stop at the equal to. And if there is a palatine cleft, and if we have not seen the posterior palatine line, we might as well mistake the glottic folds for uvula. But I mean, for you,
So
your
the
trained eyes, so it may not be the possibility.
Yeah, but if you look in a coronal plane in the
Yes,
hypopharynx, it
yes,
is
sir.
very, and I think that's the easiest plane to acquire. If you want to look at way is to look at the coronal, the hypopharynx, and you'll be able to differentiate between the epiglottic folds and the uvula there.
Yes, sir.
So the question follow up is: so should a posterior palatal line be seen in all the cases?
It is not a part of any of the standard guidelines, not of ISUOG, FMF. No, none of the guidelines say that we should be looking at the posterior palatine line. But then, more often than not, most of us who are in SFM will try to outperform the guidelines. So all of us will have these things in our protocols. So if we want to
Yes.
do, certainly we should be doing it. And more importantly, if we have other abnormalities, then we should be looking for these things like the posterior palatine line, low set ears. They may add to the phenotype, which may further help us in doing a genetic test.
I think
Yeah,
once
please.
you miss a case of isolated cleft palate, it automatically comes in your protocol the next time.
Right, sir.
Please explain how to approach the uvula. We've just discussed that. Yes, you can go actually, and but I'll tell you, it's much easier if you go into the coronal, look into the hypopharynx, and that at that point you will never make a mistake of taking an epiglottic fold as a uvula because the location is different between the two. Uh, can we say posterior palatal line in retronasal triangle when in doubt of axial view in the first trimester? No.
No.
Okay. Excellent, excellent. This there are hardly any questions. This is full of appreciation, messages from everyone. Really inspiring stuff. Alok, Varun, everyone has been getting along. Please explain how to go for visualization of posterior palatal line stepwise.
Okay. I'm so sorry I did not take that part in my presentation. I should have taken that, but then because of want of time, I simply went on to the scoring system. So first and foremost thing is that the fetus should be in supine position. Second, the neck should be slightly extended. Fetal neck should be slightly extended. And I mean, generally I take the orbits according to the ISWAP guidelines. Orbit should be facing at 12 o'clock. And even if we take a sweep from the orbits to the mandible, knowingly or unknowingly, we will definitely acquire the palate. You just have to freeze, scroll back, and look at the posterior palatine line in the way in which they have described.
Okay. Do we suggest genetic testing for retrognathia only, not having micrognathia? Naveen.
Basically, we have to suggest genetic testing, whether it's micrognathia or retrognathia, because it is a defect. And we also have to look not only at that, but we have to look at the associations. What are the associations that we see, different kinds of structural anomalies that we see, and we definitely have to suggest genetic testing. And we know that chromosome anomalies are accounting for majority of them. So that's the first thing would be keeping in mind, because that's the most common thing. So that's what we would suggest, probably a microarray or maybe a KT initially, maybe a microarray. That's what we do nowadays. And then we go ahead depending on the result of what we get right here.
I would like to add a little bit on Pierre Robinson syndrome, because I've had two cases where if you, the same plane that I was talking about that you look for uvula, the coronal plane, in a case of micrognathia, you will find that the hypopharynx is filled with an echogenic structure, and that is the tongue. That's the
Yeah,
tongue in the
that's a
pharynx sign.
tongue-filled pharynx
And
sign. Yes.
yeah, that actually is also suggestive of glossoptosis. So that becomes, I've got two cases which actually, because as a part of routine looking at the uvula, and then first time I was a little worried, what am I seeing? There's a huge mass which is being seen in that, but that is one place where you can look for. Then you have to look at posterior palatal lines, seeing posterior nasal spine considered a surrogate for presence of intact cleft palate, like CSP and CC. Like you say, presence of a CSP is an indirect sign. So somebody is asking whether seeing the posterior nasal spine considered surrogate for presence of intact palate.
So posterior nasal spine many a times will have a dropout also. Many times the posterior nasal spine is not very well seen. In 2D, in 3D also, it is mainly the interruption of the posterior palatine line which will suggest the palatine defect. So, I mean, if you want to look at the posterior nasal spine, which is such a small structure, obviously you'll be looking at the bigger structure, which is the line itself. So the line itself gives you the answer.
So even the spine is not very clear in the second trimester. It becomes more apparent towards the third.
Yeah, it's very difficult to pick that up at that time. Yeah. Dr. Manor Swami has come up with a good answer. Hereafter, we will look at both the palatine line and the equal to sign. That's the best thing to do.
Best thing.
There is no doubt about that. Now, Dr. DP Singh is asking, can facial features of Harlequin ichthyosis overlap with epignathus, even both on 2D as well as 3D reconstruction? It has happened to me when I thought of epignathus and it turned out to be ichthyosis.
My limited experience is that both of these are, rare, very rare, but these are sufficiently different from each other. Like in Harlequin ichthyosis, you see abnormalities of the lips. You have these everted lips, the eclabium, and very, abnormal fixed position of the mouth. You see scaly skin with fissures. You see ectropion, puffiness around the eyes. Whereas in when you see of epignathus, it's a protruding mass from the oropharynx, from the
The
oral
localized
cavity. Yes,
thing.
it is a
Yeah,
localized
it's a
swelling.
local.
Harlequins is a like widespread. The
The
scaly
rest
thing
of the
is the big.
fetus is
Yeah.
rest of the fetus is going to be normal. In epignathus, it will be moving quite well, whereas in when you see ichthyosis, the movements are restricted, the limbs have contractures, the skin
The foot
amniotic
length,
vesiculae.
the foot length is less.
Correct.
Yeah, there was a sign actually. Somebody
Yes.
had come a short foot length. I think it was from Mediscan Systems, that paper which had come many years back. To look for uvula in coronal section, sometimes hypopharynx is not fluid filled. How to go about, sir? You have to wait. Anyway, anytime in whichever plane you want to look for the uvula. You have to wait for the fetus to swallow some amount of fluid. So it's again. Everything in the face actually requires patience. It requires patience. You really have to wait for getting the right planes. Otherwise, you end up making, false positive diagnosis. How to diagnose low set ears on 2D ultrasound? I think it. Yeah, Alok, want to say something?
Yeah, so it is far more easier to diagnose it in the 3D. In 2D, you will have to sweep from one side to the other, see the orbits, and then you see the ear. The fetus has to be in a very good position. So it is challenging on 2D per se. 3D is much more easier.
Dr. Manor is saying yes, that with recent additions like Ultra HD and radiant imaging with color chroma, the PPL is well delineated. Properly obtained uvula can be a surrogate marker for intact secondary palate. Very true, sir. That's perfectly all right. Because yes, for the PPL, it's easier said and done, because honestly speaking, you really have to wait for the fetus to extend the neck. And that at times you may lose your patience. And so at such moments, at least you're getting a coronal and looking at the uvula can give you some kind of a reassurance. Excellent talks. How to acquire 3D for low set ears. Any specific trick up your sleeve, Alok?
So when the fetus is lying on its side and you see the ears, uh, and then you take a sweep, and there should be sufficient amount of fluid in front of the ear, and then you can easily see.
Thank you. Thank you very much. Thank you, experts. You guys are wonderful. Really, really. There is the best part is all these lectures were full of messages. They're full of messages, practical messages, how to go about, what all to see, backed with evidence, backed with the objective assessment, backed with readings as regards what are the cutoffs for everything. And so a huge applaud to all three of you. And we look forward to the fetal phase part 2. uh, so everything, in fact all the successful movies always come up with their second the season or the part 2. And so we also will have a fetal phase part 2. And so I hope we have the same number of people, much more number joining there. We'll have another set of wonderful speakers for you all. And thank you, Rima, for putting up all this together. Thank you, Vishal, and the team of Conferences International. For always being there and supporting this, and making it glitch free. That's the most important thing in a webinar. Having a glitch free webinar is definitely a luxury that we look for. And so thank you everyone for that. And over to Rima for your comments.
Thank you so much, Bimal sir. And thank you to our wonderful speakers, and definitely our audience who always inspire us by joining in such large numbers. And I think the next gen sir is taking over, and they will do wonders. Thank you so much. Thank you. Thank you.
Thank you, sir. Thank you for always inspiring us.
Thank you, sir. Dr. Bimal, sir. Thank you so much, sir.
Thank you so
Good night.
much,
Good
sir.
night.
Thank you, Dr.
Good night.
Neema, ma'am.
Good night, everyone.
Night.
Good night.